Bonjour à tous et bienvenue à ce webinaire organisé par le Fonds
Good
éducatif de la
morning, all,
Société
and
internationale
welcome to
SIDA et
this
qui est intitulé
webinar
Pourquoi les
organized by
infections opportunistes
AIS. And
restent-elles toujours
we
importantes
will
dans la
discuss
réponse au VIH? Et c'est la
about the
deuxième partie.
opportunistic infection
Je
and
suis
the
Mehdi
fact that it still
Karkouri du
matter
Maroc.
in
Je
the
suis
HIV
membre du
response.
Governing
I'm
Council
Mehdi Karkouri. I come
de
from Morocco,
l'IAS, la
and
Société
I'm a
internationale
member
de
of
SIDA.
IAS.
Et
And
j'ai le plaisir de
it's a
co-modérer
pleasure for me to
ce
co-moderate,
webinaire
to
avec mon ami
co-share
Omar.
this webinar with my friend Omar Sued.
Thank you. Thank you very much, my friend. My name is Omar Sued. I am the Governing Council representative for Latin America at the IIS. And for me, it's a pleasure to be here with you. Please note, all the participants, please note that the number, due to the number of attendee, all participants will be mute. Please note that these webinars includes interpretation in Spanish, Portuguese, and French. You can select your preferred language in the bottom bar with the globe icon. There are also live captions available. Please keep in mind that they have been generated through IA, so sorry if there is any problem with that. We have planned time after the presentation for the QA. Please send any question that you might have for our speakers, focusing on today's topics in the Q&A box at any time. If your question is specific for a specific speaker, please indicate their name when typing your questions. You will notice that there is a thumbs up in the Q&A box. This symbol you can use this symbol when someone asks a question, and if you have a similar question or if you find this question important. So please click in this thumbs up sign to help us to prioritize the questions. The recording of this session and the previous session will be available in the IIS Plus. In case you are having any issues with Zoom, you can find additional guidelines provided in the chat box. Please also send us technical questions you might have there. But remember, the scientific question is better to put it in the Q&A box. In the chat box, feel free to let us know from which country you are connecting, what is your time, or with any other information that you might consider important. We love seeing some interaction in the chat.
Merci Omar. Alors ce webinaire fait partie d'une série de webinaires en réalité qui vont nous apporter des mises à jour sur l'épidémiologie, sur le
Thanks, Omar.
diagnostic et aussi
Actually,
sur
this
le
webinar will
traitement
help
d'un
us
certain nombre
and bring us
d'infections
information on
opportunistes
diagnostic
négligées. Alors la
and
semaine
other
dernière, nous
treatments
étions
when it
intéressés à
comes to
l'histoplasmose et
opportunistic
à la maladie de
infection.
Chagas.
Last year, last
Aujourd'hui, nous
week, we
allons
talked
faire le
about the
focus sur la
Chagas
méningite
disease,
tuberculeuse
and
et
today
sur
we're going to focus
Talaromyces
on the
marneffei. Alors, à
meningitis
travers des
tuberculosis,
présentations
and with the
cliniques,
different
nos
presentation,
orateurs
clinical presentation
vont partager avec
that
nous
will be
leur point
shared
de vue,
with us
leurs
today.
apports.
We
Et puis
will
aussi,
have the
nous avons
opinion of
une
these people.
représentante de la
And we
communauté
also
qui
have
va
a
aussi
community
partager
representative
le point
who
de vue et la
will
perspective
share her
de la
testimony, her
communauté.
perspective, and
Alors,
this
nos
will be
orateurs
represent the
d'aujourd'hui,
perspective of the
nous aurons
community.
Ahmed,
Today,
Cordie
we
de
have
l'Égypte,
Ahmed Cordie. He
Lottie
comes from
Brown du
Egypt. Nous avons
Royaume-Uni et
Lottie
Oumou
Brown comes from the
Diarra du
United
Mali.
Kingdom, and we have
Encore une
Oumou Diarra
fois,
who comes from
merci
Mali.
de vous
Once
être
again,
connectés.
thank you for being connected
J'aimerais
with us today,
aussi
for participating to
remercier
this webinar.
nos
I
bailleurs,
would
TB
like
Meningitis et Gilead
um,
Science.
to also
Et à
thank
présent, on
our
commence avec le premier
sponsors,
orateur, Ahmed
Lacarinot
Cordie.
and
Alors,
Gilead Science.
Ahmed est
Ahmed will
professeur
take the floor
assistant au
first. He's
département de
a
médecine
professor of
endémique.
medicine
Il est de
and
l'université l'université du Caire.
He
Il est
hails
aussi
from,
le superviseur académique de la clinique
he's
des
the supervisor,
antirétroviraux et du centre
the
de
clinic of
dépistage volontaire
antiretrovirals,
des
and
hôpitaux de l'université du Caire en Égypte.
he
Alors, il
works
va
with
nous
the
parler
hospitals in Egypt,
aujourd'hui
in Cairo.
sur les
He will
challenges de la
talk
prise
to
en
you
charge de la
today
tuberculose
about
parmi
the
les
challenges
individus
when
qui
it
ont
comes to treat
une infection
tuberculosis
à VIH
with the people
avancée.
who
Ahmed,
have
c'est à toi la parole.
HIV. Ahmed, you can go
Thank
ahead
you,
now.
Mehdi, for the kind introduction and kind words. I'm happy to be here today to be presenting about the challenges of TB management among the individuals who are presenting with advanced disease. I hope you see my presentation now in the presenting mode. So I'm Ahmed Cordie, coming from Cairo University Hospitals in Egypt, and my agenda today to be discussing the magnitude of the problem and to have some case-based insights about this issue, and then we can focus a little bit on TB meningitis. So as you know, according to this report that have been released in the mid of July 2024, I'm living in the region with the highest rate of increasing new cases between 2010 and 2023 in the Middle East and North Africa. And according to the same report, we have only 64% of the persons who are living with HIV aware of their status. This means that we are expecting a lot of people who will be coming to care late because they are not aware that they are acquiring the infection. And I can show you also this abstract that have been presented in the European AIDS Clinical Society meeting in 2023 from our institution. It was stating that between September 2022 and May 2023, from around 400 newly diagnosed individuals, around the half of them, 42.8%, were presenting late, and 16% they were having also advanced disease. As you can see here, the wasting syndrome, lymphoma, recurrent bacterial infections, and pulmonary and extrapulmonary tuberculosis were on the top of the AIDS defining conditions that we are facing in my institution. I will show you some case-based insights about the challenges that you might find while you are dealing with the tuberculosis in the context of having advanced disease and late presentation. Case one, he was a 38-year-old male patient. He has history of taking recreational drugs over the last 15 years, and he was diagnosed to have HCV. And you know that Egypt has a dedicated screening program for Hep C. He was screened for Hep C, diagnosed, and received treatment by SOFDAC. And also, he was diagnosed to have HIV on 2017, started treatment based on TDF-FTC plus efavirenz. Then he was shifted to dolutegravir therapy because we have mass shifting for the people who are living with HIV in Egypt to receive DTG therapy. He presented to care with fever, 38 degrees, rigors, sweatings. There was no diurnal variation, but he had some bony aches, painful upper abdominal quadrant for over 1.5 months. The patient was underbuilt, and the abdominal examination showed that there was left hypochondrial tender bulge. The laboratory investigations, as you can see here, he had still detectable viremia, very low SOD4 count, only 45 cells per milliliter, some anemia, some elevation in the cholestatic hepatic enzymes, alkaline phosphatase, and gamma GT. His lubricant scan test came negative. Quantiferon gold also came negative. CT chest was clear, as you can see here in this photo on the right of the screen. And in this left side of the screen, the abdominal ultrasound showed a large collection, about 6 to 8 centimeters, related to the body and the tail of the pancreas. We started to do aspiration from the fluid. Everything came negative: cultural sensitivity, CEA, amylase lipase, cytology, Zell-Nelson, gene expert, and unfortunately, the LAM test is still the moment is not available in Egypt, and we are trying hard to have it available for the people who are advancing late to care. So our team decided to start empirical anti-TB medications because we don't have anything to be explaining having such collection, and the person here in this case started already the treatment. And with the start of the treatment, the cyst started to become smaller and smaller. And with the completion of the treatment, it was only 2 to 1 centimeter. So we need to have here the insight that there is no test to rule out to be whatever you have the test negative, molecular diagnosis, the Nelson staining, and everything came negative. And gene expert, the quantiferon gold, tuberculin, and still we have the TB behind. In case 2, he was a 25-year-old male diagnosed in May 2023. At the time of diagnosis, he had 4,000 copies viremia, also low CD4 count and the percentage. Otherwise, everything was normal regarding his laboratory investigations. He had some fever, weight loss, and generalized lymphadenopathy, including cervical and abdominal lymph nodes. And the cervical lymph nodes were fistulizing on the skin, discharging some greenish pus. We did some TB workup, the ADA, gene expert, and Magic culture, and all of them came positive. This is the picture for the fistulizing lymph node on the skin for the cervical lymph node. He started the anti-TB medications and experienced a very good response. But 9 months later, he experienced anemic manifestations. He sought medical advice again, and he found to have microcytic hypochromic anemia, mild elevation in the cholestatic pattern of the liver enzymes. The ultrasound showed a solid hepatic focal lesion, biopsied to be showing a large B-cell lymphoma. So sometimes there is a disease behind another, and TB and lymphoma, unfortunately, it is difficult to distinguish them from each other. They have similar clinical and radiological presentation, and you need to keep in mind when that the diagnosis of lymphoma should be raised when there is a typical evolution of a diagnosed TB under the treatments, for sure after exclusion of antibiotic resistance for tuberculosis. The third case, it was a 28-year-old male. He was a heavy smoker, don't have any other comorbidities, recently diagnosed with HIV. During the pre-employment testing, he underwent the basic assessment. Everything was fine. For sure, he had some detectable viremia, and he started treatment by TDF, FTC, and DTG. 2 months later, after antiretroviral therapy initiation, he presented with fever, weight loss, dyspnea, and productive cough, easy fatigability, and low lymphedema and abdominal pain. Laboratory investigations showed some anemia, hypoalbuminemia, and elevated liver enzymes. As you can see here, the viral load was almost undetectable. CD4 count is increasing in number and percentage. We've looked for the Nelson sputum was negative, blood and urine culture was negative, toxoplasma IgG negative, herpes simplex screening, and quantiferon, all of them came negative. Ultrasound showed intra-abdominal, including para-aortic lymphadenopathy and some minute splenic abscesses. All of them was lower than 1 centimeter. CT chest showed minimal bilateral pleural effusion and bilateral basal ground glass opacities and some hilar lymphadenopathy. This patient was supposed to be having iris due to having TB co-infection, and the patient was started on steroids and anti-TB medications, and symptoms started to improve. So you need to keep in mind the possibility of unmasking iris if you are not able to be diagnosing the hidden TB before starting the antiretroviral therapy. When it comes to TB meningitis, we can do the same challenges, but sometimes it is more hard when we are looking for this. For TB meningitis, among the people who are living with HIV and presenting late to care, they may be presenting in non-specific symptoms. Symptoms are very subtle, and the classic presentation symptoms and signs that all we know for having meningitis, usually they are absent. Also, we don't have any definitive test to be ruling out having TB meningitis. Maybe the CSF analysis, having some imaging, the molecular assays, they help for sure to diagnose. But if they are all coming negative, still you cannot rule out, especially if you have a high clinical suspicion for having TB meningitis for such patients. And you need to keep in mind that the diagnostic delay consequences, sometimes it increases the risk of morbidity and the mortality and having neurological sequelae. So we need to be moving in a hurry and keeping this in mind. The issue of the double etiology is also there for the TB meningitis. There is possibility for co-infections with other infections that can affect the CNS in the persons who have immune compromisation due to the late presentation. Also, we have other neurological conditions that can be mimicking and complicating the TB meningitis in this vulnerable population. So this is all should be kept in mind. Also, there is a challenge with iris because when it comes to iris, the differentiation is important because we need to know is it a TB meningitis progression. So you need to be focusing on adjusting or optimizing the medications or searching for some resistance, or it is iris, so we need to be adding some steroids as the case I have shown to you. So this is usually a complexity in the management, and you need to have some clinical suspicion while you are dealing with such cases. And I think this management complexity need to be having this careful balance between availability of anti-TB medications, availability of diagnostics, doing antiretroviral initiation and optimization in proper time. Don't be afraid to be starting the treatment because although all of this complication, the people with advanced disease usually die and they lose their lives due to the advanced disease and due to the HIV infection, not due to the TB-related complications. All of them can be managed. So do some effort to be excluding TB, to looking for double pathologies, to confirm the TB and start the treatment if it is possible. But if it is not, please don't delay starting the antiretroviral therapy and provide some close monitoring. And also, I think we have on board a lot of the peers and community supporters. So we need the people who are presenting late to care to be aware of this, to know when they should be worried and when they should ask for care and come back to the clinic and show that they are not feeling comfortable with having fevers, having body lumps or some lymphadenopathy. All of this should be taken in mind, and we should do some of training for the persons who are presenting late to care about this. For sure, the multidisciplinary approach is the optimal management way to have the not only the ID physician, but also to have neurologists, to have the nurses and the lab workers, and to have also the peer supporters and the community workers all on board, all working with each other to be supporting such persons. I think now I'm coming to the end of this presentation. Maybe I'm a few minutes before the allocated times, but I was trying to be on time and to be more concise with sharing this idea. And I think we can have this time for some discussions or questions if it is possible.
Thank you. Thank you very much for the presentation, and thank you for saving some minutes for the discussion. We will pass to the next speaker. We will leave the question for the end of the three presentations. We will pass to Lottie. Lottie Brown is a junior doctor and NIHR-funded academic clinical fellow and infectious disease and medical microbiology at the St. George University and Hospital in London. Lottie will be presenting on Talaromyces, a neglected tropical disease in Southeast Asia. So thank you very much, Lottie, for being here. The floor is yours.
Okay, thank you so much for the invitation to speak today on my favorite topic, Talaromyces. And before I get started, I just wanted to acknowledge all of those researchers who are involved in this fantastic network across Southeast Asia and also at partner institutes at Duke University. And a special shout out as well to my supervisor, Professor Thuy Le, who's coordinated much of this effort of Talaromyces research. So I was going to start with the very basics because I think many of the people listening today have probably never seen a case of Talaromyces. And that's not because it's a rare disease. It's because the disease is caused by a endemic fungi called Talaromyces marneffei. Now that's quite a mouthful, so I'm going to shorten it to TM for the rest of the presentation. Talaromyces is a thermally dimorphic fungi. It's endemic to Southeast Asia. Thermally dimorphic just means that it switches from a mold to a yeast, depending on the temperature. And in these hyperendemic regions, particularly Vietnam, Thailand, southern China, and northeastern India, it's actually one of the most common opportunistic infections in advanced HIV disease. And the deaths surpass those from other major killers like cryptococcal meningitis. But historically, this is a disease that's received very little programmatic attention and resources. And that's despite the very high mortality rate of about 30%. I'm glad to say that things are changing. So in 2022, TM was named WHO fungal priority pathogen. And we can see that although the area of endemicity is very much restricted to Southeast Asia, we've seen a expanding geography and a rising incidence year on year. So 90% of cases of Talaromyces are associated with advanced HIV disease. We have 3.5 million living with HIV disease in the endemic regions, and 40% of those people are not receiving ARTs, which is an issue which is only going to be exacerbated by all of this turmoil, which has been caused by the political events in America. I think the ecology of Talaromyces is a really interesting area. So what we've known for many years, is that the bamboo rat pictured here is the only zoonotic reservoir for disease. Bamboo rats are these very large mammals. They can grow up to 0.5 meter long, which I think is a terrifying thought. And they are present across the highlands of Southeast Asia. They form these extensive burrow systems around crops and are regarded as agricultural pests. But they're also farmed and eaten for meat in some areas. Now, we have no evidence of direct bamboo rat to human transmission. What we think is probably happening is it's the soil associated with these mammals, exposure to this soil, that's driving the acquisition of Talaromyces. And we also know that there are some environmental factors at play. So during the tropical monsoon season, the incidence of infections rises between 30 to 73%, probably due to increased temperature, precipitation, and humidity, which drives the growth of TM. There's only been, this just demonstrates how neglected this disease is. There's only been a single case control study investigating risk factors for Talaromyces. That was done way back in the 90s in Thailand. But we were interested in understanding the risk factors in Vietnam. And this is our study, which is just about to be published in Emerging Infectious Diseases. It was a case control study of over 600 people with advanced HIV disease. We matched cases and controls based on age, sex, CD4 count, or where that wasn't available, and it's often not in Southeast Asia, the absolute lymphocyte count. We found in our multivariable analysis that exposure to tropical plants and exposure to farmed animals significantly increased the risk of developing Talaromyces. And that was in line with the findings of that previous study from Thailand. Where our two studies differed was that exposure to soil was not a risk factor for disease in our work. And what we think is happening is that it's actually a very specific type of soil associated with animal excreta and with decaying tropical plant substrate, which is preferred by the TM. We also did geographical mapping of cases and controls. And what we found is that participants from the highland regions, which I'm just showing with my clicker here, they were 8 to 10 times more likely to develop Talaromyces compared to those in the lowland regions. We kind of expected that. That follows the distribution of the bamboo rat. But what we didn't expect was that people who had ever, at any time in their life, resided or travelled to these highland regions had a 3 times increased risk of developing Talaromyces. And we therefore demonstrated the first epidemiological link between travel or residence to highland regions and human Talaromyces in this highly endemic setting. Moving on to the pathogenesis now. Well, the lungs are the primary portal of entry for TM in both the human and the bamboo rat. They cause an acute respiratory tract infection. In the lungs, TM is rapidly phagocytosed by alveolar macrophages. And inside, they undergo this dimorphic switching from mold to yeast, which appears to be advantageous to their survival. It allows them to survive phagocytosis. TM also produces large quantities of this MP1P protein, which binds to arachidonic acid and disrupts the host pro-inflammatory cascade. Now, the progression and severity of TM infection is very much dependent on the CD4 T cell Th1 pathway. That's why we see this disease in people with advanced HIV disease. And defects in this pathway impairs the macrophage and B cell activation, which are crucial for effective control of TM. And without that, TM is free to proliferate and disseminate throughout the reticular endothelial system to cause this multi-system infection that we call talaromycosis. So diagnosing talaromycosis is very much a challenge, and that's because the clinical features are very non-specific and overlap with other opportunistic infections that are present in Southeast Asia. Skin lesions are the most specific sign, but they are only present very late on in the infection when it's widely disseminated, and they're absent in many cases. And you can see they could easily be confused for a histoplasmosis skin lesion. We don't recommend initiating empirical antifungal therapy for a number of reasons. So we need good diagnostics. That's what's going to be crucial to preventing deaths from this disease. Now, for many years, the diagnosis has relied on our conventional methods, microscopy, so demonstrating the characteristic yeast cell with the central septate there, and by culture of blood or other clinical specimens. But the major issue is that they lack sensitivity. Blood culture misses about 50% of cases, and they're particularly poor at picking up early stage infection when you can initiate treatment and it's most likely to be effective. But there have been major progress made in rapid diagnostics for talaromycosis in recent years. Here's our diagnostic pipeline, and we can see that we've made great progress with the enzyme immunoassays, including the first prospective trial that's been just completed in the last 12 months. And LFAs have also been developed, as well as molecular tests, including qPCR and next generation sequencing, and even host-based assays are now in the early stages of development. This is our MP1P EIA. I think you'll remember from my pathogenesis slide that the MP1P is this protein that's secreted in abundance during acute infection, and is highly immunogenic, so it makes it an ideal immunodiagnostic target. This is the prospective validation of the MP1P EIA, which tested a large prospective cohort of over 500 patients with advanced HIV disease in southern Vietnam and followed them for over 6 months. What we found is that urine was the best specimen to use for this test, giving a sensitivity of 93% and a very high specificity of 99%. But the best strategy was actually combining plasma and urine together. When I say combined testing, what I mean is positivity of either plasma or urine was considered a positive test. That gave us a sensitivity of 96% while maintaining a high specificity of 97%. But what was really interesting is that we found that MP1P antigenemia preceded blood culture positivity by up to 16 weeks. And this brought about the potential for the test to be used for targeted screening of patients with advanced HIV disease before the onset of clinical symptoms, rather like the CRAG test is being used for cryptococcal meningitis. There have been several point-of-care tests developed for talaromycosis. I'm going to focus on the MP1P LFA developed at the University of Hong Kong in collaboration with IMI. We have the most data for this LFA. We can see from the kind of protocol here, it's incredibly simple to use, results in less than 15 minutes without electricity or specialized lab equipment. So it's suitable for community settings, remote settings at the point of care. This was the first comparative evaluation between the MP1P LFA and its EIA platform. Although the LFA sensitivity is inferior to the EIA, which is to be expected for a lateral flow test, it's still pretty good, 91%, and it's significantly better than blood culture, while providing the major advantage of results in less than 15 minutes. So at the moment, the WHO recommends screening for TB and Cryptococcus in the advanced HIV disease package of care in Southeast Asia. But invasive mycoses, Talaromyces, Histoplasmosis are left out of this equation. And that's probably due to a lack of diagnostic data and a lack of disease burden data. So in response to this, Professor Lei and her team conducted a prospective study of triple fungal screening for patients with advanced HIV disease in Vietnam. And these are the preliminary findings. So this was a very large multi-center prospective cohort study, 900 inpatients, 500 outpatients. We can see that of all the patients screened, nearly 20% had Talaromyces. That's massive. That's higher than Cryptococcus, Histoplasmosis, and NTM combined. And a significant proportion of the outpatients were also affected. The next stage of this analysis will be to correlate it with clinical outcomes, and I'll be really interested to see that data when it's made available very soon. Moving on to the molecular test now, well, there have been several qPCR assays developed over the years. Unfortunately, they've had pretty variable, not great sensitivity between 60 and 80% when tested in a limited number of patients. This is my colleague Kan's master's project, actually. He was tasked with optimizing qPCR for TM, and he did a fantastic job. So he used 5AS primers, that's ribosomal RNA primers, DNA extraction using the MasterPure fungal kit, with whole blood, 1 ml of whole blood, and he actually achieved the highest analytical sensitivity to date, with the qPCR able to detect as low as 1 yeast cell per ml of whole blood, with no cross-reactivity to 15 clinically related species. He took this forward to a clinical evaluation of 170 patients with advanced HIV disease. Overall sensitivity was the best to date, 88%. It was excellent in blood culture positive cases. Unfortunately, in blood culture negative cases, we can see that there's still some work to be done, and we have some further optimization experiments planned. The specificity was excellent, being 97%. So this brings us through to our diagnostic algorithm for TM. And I think the main takeaway points is that despite the many advantages of our novel diagnostics for Talaromyces, they shouldn't replace our conventional tests, which remain crucial for antifungal susceptibility testing in the instance of failed treatment, and they also add to the overall diagnostic yield. A positive qPCR and a positive antigen test in the context of a patient with clinically compatible symptoms should be considered a true positive, and they probably should be initiated on antifungal therapy. The last thing to say is that we also advocate for the use of selective fungal mycobacterial blood culture. An example of that would be the mycoathlytic. They're these special blood cultures that are incubated for 42 days. And they have the secondary advantage of picking up histoplasmosis, tuberculosis, and NTM, which are highly prevalent in our patients with suspected Talaromyces. And indeed, we see a lot of co-infections with those pathogens. Moving on finally to the therapeutic aspect. So there's only been one randomized controlled trial for Talaromyces. That was the IVAP clinical trial done in 2017, which compared amphotericin B deoxycholate induction therapy, so 14 days, versus the standard of care, which was itraconazole. And we can see that deoxycholate amphotericin was highly potent, much better than itraconazole for treating Talaromyces, but it's also highly toxic. So over 50% of the participants in the amphotericin arm experienced grade 3 adverse events or higher. Some really interesting work is going on at Duke, looking at in vitro efficacy of amphotericin B with different combinations. This combination is a pretty common one now, following on from the cryptococcal meningitis trials. I think it's also going to be used in Candida as well. It's amphotericin B and 5FC. And they demonstrated partial and full synergy in checkerboard assays and time to kill experiments. And the major advantage is this drug combination has an excellent safety profile demonstrated from the cryptococcal trials, and we know it's safe. And that leads on to our next clinical trial, which is the LAMFAST trial, which will compare a single dose of liposomal amphotericin B versus deoxycholate amphotericin B for 14 days as induction therapy, plus or minus the combination of 5-FC. And a secondary outcome of this trial will be to look at when is safe to stop itraconazole maintenance therapy. So following induction therapy, it's recommended currently that itraconazole is continued until the patient has immune reconstitution, which can take a very long time, up to 24 months, as we all know. And that obviously has implications on drug costs, on adherence, and on side effects and toxicity. So this part of the trial will look at whether it's safe to stop itraconazole short. So I'll finish there, and I just want to again acknowledge all of the people involved in this fantastic network of Talaromyces research, and I'm really happy to take any questions and discuss with you in that part of the seminar.
Merci beaucoup. Merci Lottie pour cette présentation. Et nous allons à présent passer à notre troisième
Thank you,
oratrice.
Lottie, for your presentation. Now we are going to go to Oumou Diarra, who is the director of the network in Mali of the associations who work with the HIV patients. She will give us the opinions or some information coming from the community. Oumou can take the floor. In 1997, I found a lump in my right neck. And I went to see a dentist. He referred me to a tuberculosis diagnostic and treatment center. It was there that I underwent sputum tests, and the results came back positive. Then they prescribed the treatment I needed, which included 8 months of treatment, including 2 months of injection, lots of shots, and 6 months of taking pills. That wasn't easy. It made me very tired, but with courage and support from my family, I completed the treatment. After the treatment was over, I went back to the treatment center, and they did the sputum test once again. The results were good. A short time later, the lump came back even bigger than before, so I was referred to the Pongé hospital. They checked my lump and decided to proceed with the biopsy to better understand what was going on. And then they asked me if I would agree to have an HIV test. It wasn't easy at the time, you know. Well, I agreed anyway to do it. I was only 24 years old, so the results came back positive. It wasn't easy. It wasn't easy because I told myself that I wasn't married and I was 24. I didn't have any children. So my life ended right there. So therefore, my situation seemed even more difficult. For us, HIV means death. So I was referred to the CEST Center in Bamako, which is the first Arcade Santé Plus center. So really, it's a community center where they administer the confirmation test, and it came back positive again. Well, you know, with all the support from my family, everything, and other people who also had AIDS. And, you know, in this context, it was hard because we knew that there was no treatment, or if there was one, it was too expensive. And with all the support, thank to God, with all the partners, this group was able to give us the treatment, and I was part of this giving. And my CD count, then when I started the treatment again, my CD count was starting to drop and I had itching all over my body, but I continued with the treatment. And in the meantime, I continued to contribute to the Women's Aid and Support Association, initially to help them with some administrative tasks. So at first, I just wanted to continue with support. So we continued with the project until we were able to form a choir with the CESAC. Our headquarters was at the CESAC Center in Bamako, so it was like family. So one day, the choir went out to give testimony, to sing in front of the authorities, to say that we live with the VIH, with HIV, and that there was no medication. And upon our return, since the theme of the International Women's Day was Women and Aid, we were given the opportunity to express ourselves. So for the occasion, there was a large delegation of different authorities that were present, and they took the initiative to launch the Malian Initiative for access to antiretroviral drugs, which has ensured that this treatment could continue and that they would be free. Thank God, today I'm married, I accompany my peer, I support my peer, and today I play a great role within the association, particularly in Mali and in the Malian network, associations, and all sorts of associations among people. And I gave birth to children who are not infected with HIV. Today, my greatest satisfaction is that I have given birth to children who will not be infected with VIH. My second source of satisfaction is being considered a source of inspiration by the children I have seen being born and grow up, who are now standing up for themselves despite the stigma and the discrimination they face. Community organizations in Mali play a vital role in the response to pandemics, particularly HIV, AIDS, and tuberculosis. We have been trained and supervised to become psychosocial counselors, or CPSs. We provide guidance and support to our peers, but we also work to prevent disease and raise awareness in the community. And in response to opportunistic infection, particularly tuberculosis, we play a role in assessing patients using a questionnaire, where we ask them questions such as this. Have you been coughing for more than 2 weeks? Have you been sweating at night? Have you lost a lot of weight? So if there are any doubts, if we really suspect that they may have tuberculosis, we refer them to the diagnostic and treatment centers. And we also conduct an investigation with the patient's family and friend, and so they can get tested. But we also do a DBC to ensure good adherence to the ARV treatment, taking care not to make assumption if the patient tests are positive. But then we play a real synergetic role with the facilitators from SAS, Synergy, Action, and Health Mali, which is an NGO that really takes care of tuberculosis patients as part of the fight against that disease. They bring support during the follow-up so that these patients can really take their ARV treatment properly without any problem. They also really take care of tuberculosis patients as part of the fight against tuberculosis, and also provide support and follow-up so that these patients can really take their ARV treatment without any problem, and also to prevent tuberculosis. With regard to the challenges and impact of opportunistic disease management, despite concentrated effort, some challenges remain. There are shortcomings in technical facilities, especially in public sites. There are also paid services. There are concerns for drugs and tests that patients cannot afford. Some patients really don't have the means for this. Regarding public community sites, there's no problem. Community sites have opportunistic drug available. Even if they don't have the entire list of prescribed products, they are still available. And it is also a fact that there are not enough community sites in the country. So this is really one of the challenges that people with HIV face at the national level.
Thank you very much for this testimonial, Oumou. As you noted, this testimonial has been recorded because the electrical problem that we have in Mali, and we couldn't ensure that Oumou will be on live. But fortunately, we have her here, and it will be a pleasure to receive question for her. And I really liked your testimony that talk about the transformative power of the communities and also the value of the you equals you to enjoy a full life, as Oumou is mentioning. So thank you very much. So if you have, dear participants, if you have any question, please put your question in the QA box, and we will start now the QA session with my friend Mehdi. Go ahead, Mehdi.
Merci beaucoup, Omar. Merci à nos trois orateurs. Merci d'avoir
Thank you,
participé leur
Omar.
point de
Thank
vue.
you
Alors,
to the three
on a
people who
plusieurs
share their
questions
point
qui
of
sont
view
déjà
with
posées
us today. We have a few questions that were already
les
asked
participants.
by the participants.
Dr. Cordie a répondu à quelques questions
Dr.
qui
Cordie
concernaient
has
la
himself
tuberculose. Alors,
responded to
j'en
some of the
vois encore
questions concerning
quelques-unes
tuberculosis. I
parmi
can still see
les
some
questions posées.
questions in the Q&A
Comment
box.
est-ce qu'on peut assurer un
How
bon
can
management des
we guarantee a
corticoïdes
good treatment, a good
si la tuberculose
management
survient
with
sur un terrain
corticoid
d'immunodépression
if
aggravée?
the tuberculosis comes in a state of immunodepression with HIV? Sorry.
I'm sorry, Mehdi. The question is not clear, very clear for me. We are talking about the safety of using steroids for the person with it. This is right?
Yes, yes. Oui.
So I think here we have two places for the steroids for while we are managing such cases. The first, when we are diagnosing TB meningitis, there is a room for adding steroids with the start of the anti-TB medications. There is some data that can reduce the sequelae related to the subsequent fibrosis and reduce the sequelae that can come up with the clearance of the TB meningitis. And also, if we have the diagnosis and we need to start the antiretroviral therapy, also there is some supporting evidence that we can add some steroids to prevent the paradoxical iris with such persons. As long as we are adding steroids under the coverage of having antiretroviral therapy and having the anti-TB medications, I think it is safe, and we have already got experience with using steroids in such persons. Hopefully, I was able to answer the question well if I got the point.
Okay, thank
Merci.
you, Ahmed. I will go with Lottie. We usually go one Mehdi, one myself, so I will go with Lottie. Thank you, Lottie, for your wonderful presentation. I wonder about the similitudes and the difference between Talaro and histoplasmosis. As in Latin America, histoplasmosis is much more Talaromyces doesn't exist practically, and histoplasmosis is very, very frequent. But as you presented, I saw it's quite similar. There is a clinically and the also, I mean, histoplasmosis, the reservoir is more the some beers, but of the rest of that, there is a lot of similitudes. I wanted to ask you about the level of CD4 that what is the impact of the level of CD4? We are seeing here that patient with less than 200 CD4 has the highest risk for disseminated histoplasmosis. So no less than 100, or is the risk really increase significantly with less than 200. Obviously, as low as is worse, but also there are small moderate or no as severe cases with patients between 200 and 350, more or less. So I don't know what is the experience with that in talaromycosis.
Yeah, thank you for your question. I think it's an excellent point. There are lots of parallels between histoplasmosis and talaromycosis. And they're really tricky to diagnose and differentiate between the two in Southeast Asia, because we know culture is very, very poor at picking these up. And clinically, you could see on those pictures, they both cause pulmonary issues, and they both have very similar skin lesions. In terms of the CD4 count, yeah, completely right. So your highest risk is within if the CD4 is less than 200. We also think that Talaromyces can affect actually immunocompetent people. We think it probably causes an acute respiratory tract infection comparable to blastomycosis in the US. And actually, at the moment, we're undergoing some antibody studies to try and clarify this. But yeah, we think it can affect people with CD4 greater than 200, but significantly, the risk for disseminated disease with that high mortality of 30% is seen in patients who are profoundly immunosuppressed.
So now that the WHO has mm, make more clear the algorithm for diagnostic TB with LAM TB to less than 200 CD4, it makes a perfect situation to use in any patient with less than 200 CD4 the antigen for TB, for crypto, and for Talaro, at the same time as we
Yeah,
are
and
doing in
histo.
Latin America. Yeah, we
Yeah,
are doing that in
exactly.
Latin America with Histo. Yeah.
Yeah. So the
Okay.
perspective, yeah, thank you.
No, no, we go ahead. Sorry, I could your perspective, you say.
Yeah, so I mean, one thing that was a little bit unexpected in the prospective trial that I showed, 900 inpatients, 500 outpatients, was actually quite a significant rate of histoplasmosis in Vietnam. There's not been any good screening studies done before, and we knew it was there based on some case reports, but actually in inpatients it was 3%, which is really quite high. So we
Yeah.
are advocating for screening for crypto, Talaromyces, and histoplasmosis antigen tests in patients with CD4 less than 200.
We will actually test antigen test to test Talaromyces in Latin America then, just in case. Okay,
Yeah,
Mehdi,
good
back
idea.
to you.
Merci. On a une question pour Oumou. Oumou, est-ce que vous nous entendez? En fait, la
We have
question,
a
c'est
question for
est-ce
Humu.
que,
Humu, do you
d'après
hear
votre
us?
expérience sur le
In
terrain,
your
est-ce que vous pensez
experience
que les
on
personnes
in the field, do you
qui
think that
souffrent
people who
d'infections
suffer
opportunistes,
from
est-ce
opportunistic
qu'elles souffrent
infection,
aussi d'une
well,
stigmatisation
do
plus
are they
importante
do they also
que
suffer
pour
from
les
that
autres
stigma?
personnes vivant
Is
avec
it
le
worse
VIH?
than the
Oui.
one suffered by
La
the people
question
living with
est,
the
en
HIV?
partant de
Okay, the
votre
question again.
expérience terrain,
According to your
voyez-vous que les
experience in
personnes
the
vivant
field,
avec le VIH
do
qui
the people
souffrent
living with
d'infections
uh,
opportunistes, comme par
uh,
exemple la
HIV,
tuberculose,
who
dont on
have
a
other
parlé
diseases
aujourd'hui,
such
est-ce
as
qu'elles souffrent
tuberculosis,
d'une
well, are
stigmatisation
they more
plus importante
stigmatized
par rapport aux
than
autres personnes
people
vivant avec le
living
VIH?
just with HIV? Are they more stigmatized? Yes, because for them this is a pathology that can be transmitted. It is worse than a person who just suffer from tuberculosis or just the HIV. There's more stigma and discrimination in that case. There's more stigmatization with the person who lives with tuberculosis. Though there are patients who are rejected by their peers or by their family members. We had to host that person, and we have some time where we have to deliver the medication to the patient. We cannot have the patient come to us. We have people here who have tuberculosis, and the stigmatization was very strong. So we had to go and help them. We had to bring support to them.
D'accord. Merci.
Thank you.
Merci.
Thank you, Humu.
Merci. Mais peut-être une question pour Dr. Cordie.
Maybe we have another question for
Donc, on
Dr.
a une question
Cordie.
sur le test
We have a
antigène
question
LAM
about the
qui,
LAM, the
quelqu'un
antigen
demande, il est
test.
parfois positif chez des
Somebody
patients
asked,
vivant avec le
it could be
VIH, mais
positive
sans
for
qu'on
the
puisse
people
trouver
who
une
live
localisation
with
tuberculeuse
HIV.
évidente. Quelle est votre
And
approche
sometimes it's not
de ce
logical for
problème?
tuberculosis. So what is your approach to that problem? How do you see that problem?
I think it depends on the proper selection of the person who is taking benefit of using the lamp. because according all the guidelines and the manufacturer advice, it should be dedicated for the persons with advanced disease with CD4 count less than 200. And yield is better when you have a person who is critically ill or a person he is presenting with TB symptoms and signs. But using the LAM test a screening tool for the persons with CD4 count more than 200, I think it can carry a lot of fallacies. I'm not aware of if any supporting evidence for using it in this way, but I think it is not because the issue of releasing the antigen through the podocytes of the kidney is related to the pathogenesis of the advanced disease. So we should have the advanced disease in the background or being critically ill to have a proper diagnostic yield for such a test.
Eh bien, Omar, peut-être que je vais rajouter une
Yeah,
question.
thank you. Yeah,
Une
thank you very
question.
much, Mehdi. My
OK.
question is for Oumou. Thank you very much for your presentations, your testimony. My question is what is your advice for people living with HIV in areas or countries where no civil organization are in order to try to build some kind of support for those patients? I don't know if it's clear, the question.
Question s'adresse à moi, n'est-ce pas? Oui, effectivement, actuellement, il y a d'autres
Yes,
organisations vraiment
right
qui
now,
s'occupent de ces
there are
patients.
other organizations that take
Mon
care of
témoignage,
that
c'était
problem.
avant, bien avant qu'il y ait plus d'organisations. Mais
Before,
actuellement, notre réseau a plus d'une
we had
quarantaine
more.
d'associations de
Now
personnes
we
vivant
have
avec le VIH.
more than
Donc, dans toutes
40
les régions, elles sont
associations
organisées même
in all
par réseaux
regions.
régionaux
These
et
associations
affiliées à
are
notre réseau
very
international.
organized and they're
Donc,
affiliated
rassurez-vous,
to
actuellement, les
all
CPS sont dans
the
toutes les
regional
régions. D'ailleurs, dans la
headquarters.
subvention
We
du
have that in all
G7,
regions.
on a une soixantaine de conseils
We have
psychosociaux qui jouent ce rôle
more than
d'accompagnement des
60
Haïtiens et
social
de maintien
concepts
aussi
who bring
des patients
support
qui ont été
to
formés
patients.
vraiment pour
And
pouvoir
these
accompagner
people were
leurs patients.
trained in order to
Merci.
accompany or to support patients.
Je pense que j'ai
Thank you.
répondu à la question. Vous
I
êtes
think
satisfait?
I responded to the question, didn't I? Did I answer your question?
Maybe we can extend to the part of what is your advice for people, those people living with HIV that doesn't have access to this community, how they can build one?
Les personnes vraiment qui n'ont pas accès à ce service-là,
The
je
people
pense
who
qu'il
don't have
y a une
access to all
sensibilisation de
these
la
services,
communauté
I think there
qui
is a
vraiment
certain
permet vraiment aux
engagements
gens
and
non
a
seulement d'aller
of
se
the
faire dépister.
community,
D'ailleurs,
and
maintenant,
there is
nous-mêmes, à
uh,
travers nos
they can
sensibilisations, parce
go
qu'on
and
plaide
get
vraiment au
tested.
dépistage, je
And
dis la
we
vérité.
do
Donc, s'il y a
help
des
in
cas positifs,
sensibilize
que ça soit au VIH,
and
il y a
sending
une
information
référence
to
vraiment au
the
niveau
people.
des sites,
We have a
des aires de
reference.
santé dans
We
laquelle
make
la
references to
personne
all
vraiment
the
veut
sites,
fréquenter.
and
Et vraiment, il y a une
people
test de
can come
confirmation
to
qui est
those
faite avec
sites.
le
And
soutien
we
vraiment du
also
médecin
bring
traitant
a
de cette
confirmation
localité.
test
Et
that,
si ce test
and they
révèle
can do
un
that
cas
with their
positif,
general
vraiment, il y a tout
practitioner, their
l'accompagnement,
doctors.
les
But
activités
then
de
we
support et
bring
de maintien aussi.
support.
Et
We
aussi, il y a la
have
DBC.
activities,
Au cas où la personne
and
est à
we
un
also
stade
have
qui est
DBC.
cliniquement stable et que le CD4 commence à
And
s'améliorer.
then,
Il
in
y a des
case
problèmes
that the
d'acceptation.
person really
Des fois,
have
la
a
DBC
problem of
dispensation à base
transportation, we
communautaire où
bring
elle prend les
support in that
médicaments
sense.
pour
So
aller donner à la
we
personne
bring the
selon vraiment le niveau
medication as
progressif
well.
de
We
l'immunologie.
bring the medication if need be to the person.
Thank you very much. So it's important. Just wanted to clarify that because it's important that everybody has the right to have access to support and the right to receive some different, I mean, not only antiretroviral, but also all this comprehensive care that help to enjoy life as Oumou is having. Thank you very much, Oumou, for your testimony. Go ahead, Mehdi. Go back to you.
Okay. So we have a question. Someone is asking
that.
that situation in Africa, the ecosystem in Africa is close pardon, je dois parler en français. Là, il y a beaucoup de similarités dans l'écosystème entre
There are a
l'Asie et
lot of
l'Afrique. Est-ce
similarity
que le risque de
in the ecosystem between
talaromycose est
Asia
possible pour l'Afrique?
and Africa as the same risk of
Merci.
Yeah, my
Talaromyces
school friend
for
managed
Africa.
to let me understand that. So, yeah, I mean, I think it's a great point. I did see one study that did some PCR work in Central Africa and had some positivity. It was some environmental sampling, but we were not sure if it was just that the PCR assay being used had low specificity. I think as of yet, there's been no case studies of a case of Talaromycosis in Africa, except for travel-related cases. Actually, interestingly, there are cases of Talaromycosis in individuals who have not visited Southeast Asia for up to 50 years. So there's obviously a risk of latent infection there. With global warming and with increased kind of travel and migration, I think it's definitely an ongoing risk and something that we need to be wary of over the next few decades. It's definitely possible. There are some similarities in terms of the geography and the climate in parts of Africa with Southeast Asia. So I think there is an ongoing risk there. Thanks for the question.
Merci. Dr.
I will
Thank
pick up. I
you.
will pick
Thank
up
you.
Okay,
someone for Cordie, please,
please.
Ahmed, because I like the tuberculosis very much, and I have two specific topics here that, or one specific question that say that sometimes the lamp for tuberculosis is positive in asymptomatic people, and the doctor cannot find other confirmatory tests for tuberculosis. So there is a discussion about how to manage those patients and when to consider a positive lamp positive in TB patient or not, in patient with symptoms or not. How do you address this situation?
I think if the person is symptomatizing, even if we don't have the positive lab test, we can go for the treatment because I just was sharing with you that even if we have all the tests negative and we are have a clinical suspicion of having TB, we have to start the treatment for tuberculosis, and we have a lot of supporting evidence from the studies and even from our own experience while dealing with such cases. And for sure, having LAM test in a person with advanced disease would be more supporting to start the treatment for such a person.
Yeah, yeah. So your recommendation is that if they don't have any other positive test, like I just say, some patient in your presentations, your first clinical case that doesn't have any positive
Yeah,
test,
that's right.
but some patient will benefit of empirical treatment. So the recommendation for in particular with less than 200 will be treat and
Yeah,
then see what happens. Thank
totally
you.
agree. Yeah,
Thank
thank
you.
you.
And maybe the same question for Lottie, because Lottie presented in the algorithm, the antigen test is enough for the treatment for those patients? Because in your
Yeah.
algorithm, you were referring some of the patients to the PCR for culture.
Yeah, so what we say is that if you have a positive PCR, it's good enough to indicate that Talaromycosis is there, and we say that you should treat. If you have a positive antigen test in a patient with a compatible clinical syndrome, which is obviously quite non-specific, but if there is a strong suspicion there of Talaromycosis, we say that it's highly indicative of infection and you should strongly consider starting your antifungal therapy. But while that's going on, you should still make all efforts to confirm the diagnosis by other means. And obviously, positivity of two novel diagnostics is stronger than positivity of a single one. So, if you've got a patient who's positive by antigen test, try and get the PCR, try and get the conventional diagnostics. And particularly that selective mycobacterial fungal blood culture can be really beneficial. Obviously, you have to incubate it for 42 days, but it improves your diagnostic yield compared to normal blood culture by 30%. And you can also pick up some of those other important pathogens, histo, TB, while you're doing that. So we really advocate for the use of those.
Thank you. In Latin America, in comparison with histoplasmosis, the PCR in histoplasmosis is very low sensitivity at this
Yeah.
moment. So we are expecting to see the results for first PCR. But so in the region is the indication is directly to try to treat because I mean the antigen is quite good, and if there is any suspicion or any doubt, maybe using another antigen base like ELISA, but the recommendation in the guideline, in the WHO guideline, is directly in histoplasmosis to use the antigen as the diagnostic test and treat because there is no much capacity for culture because the need of biosafety cabinet for this specific fungus in Latin America. So I don't know if it's similar the situation of the laboratories in the region
Yeah,
in Asia.
it's exactly the same. It's a high risk pathogen, so you need it needs to be done in category 3, and that again is one of the challenges, and that's why I think things like the lateral flow tests can be so useful because you can do those at the
Yeah,
bedside. You don't need any
yeah.
specialist laboratory, no infrastructure. So that's a really exciting area as well.
Okay, thank you. Mehdi?
Euh, Docteur Ahmed, on a une question sur est-ce
Dr.
que vous
Ahmed,
avez
we
une
have a
expérience
question. Do
dans
you
la
have a
gestion de la
experience
tuberculose
when it comes
résistante
to
chez les patients
tuberculosis
qui ont une
treatment
infection AVIH
that is
avancée? Quelle serait
resisted
votre
when the
recommandation
patients have
pour faire
HIV,
justement le
but at the
diagnostic de cette
advanced stage,
tuberculose
what is
résistante
the way
dans un
you do a
contexte
diagnostic
où les
of
tests pourraient
resistant
être
tuberculosis
négatifs justement en raison
when the test
de
proved to be
l'infection
negative
AVIH avancée?
because there is a HIV infection that is quite advanced?
Yeah, this is a good question, Dr. Mehdi, and I think I have already mentioned this because when you are dealing with the advanced disease and you have the diagnosis of tuberculosis and the person is not responding well, so the problem here, you need to distinguish the possibility of having resistance from the possibility of having iris, from even having a double pathology or another disease that can be behind having the tuberculosis. From my experience in this work, because we also sharing with a lot of African countries the limited access to testing facilities, we can do this case by case. So you can find sometimes the clinical scenario is moving toward to have that the TB here is resistant, and also every country should have some epidemiological data about the prevalence of the resistant tuberculosis, because what is common is common. We don't have resistant TB at the first thing to think about when the person is naive to treatment and have been never exposed to anti-TB medications. I'm talking about Egypt. Maybe other countries have higher prevalence of resistant tuberculosis among their population. The other issue that the clinical situation can also direct us to be thinking about having another pathology or thinking about iris also, for example, as something that can mimic the tuberculosis progression.
Merci beaucoup. Et nous avons aussi une autre
Thank you
question
very much. We also have another
d'un
question.
participant francophone qui
Is a
demande,
French
dans le
participant,
contexte actuel
francophone
où
participant. In today's context with
beaucoup se penchent
COVID-19,
en premier
a lot of
vers le
people
diagnostic de
will go
COVID-19 au
towards
détriment
the
de la
diagnostic
tuberculose.
of the
Qu'est-ce que
COVID-19
vous en
and won't do
pensez? Est-ce qu'il
the
faut toujours
diagnostic for
systématiquement
tuberculosis.
penser aux deux?
So therefore, what do you think? Do we have to think about both automatically, or should we carry on like this?
I'm not sure if I'm getting the question well, but the question here is about doing dual testing for the tuberculosis and COVID-19. You know that the clinical presentation for the COVID-19 and tuberculosis a little bit different. COVID-19 is an acute disease, acute viral infection, but for tuberculosis, it is more subacute presentation and more chronic symptoms. But the good part of this question is that we for sure can reuse the testing facilities and the efforts that have been done during the COVID-19 by having the machines for testing the PCR, for example, to do better testing for the HIV-related infections and for viral hepatitis. And I think a lot of countries started to make use of this. So, as you know, during the time of COVID-19, there was a lot of improvement in the testing facilities and investment in making this available. So reusing the COVID resources for managing and diagnosing TB, HIV, and viral hepatitis, it's a good issue for sure.
Merci, Omar.
Thank you so much, Omar.
Yeah, thank you. Cordie, Ahmed, let's to recap the part of treatment because there are many questions about what is the best treatment for HIV, what is the best timing for HIV, for HIV treatment, and how to manage patients that are re-engaged with suspicion of meningitis, but already restarted antiretroviral before the diagnostic. If continue the treatment, stop the antiretroviral treatment, or look for iris, what to do. So it will be good to have these 3 points for
Yes.
recapitulation. I know you presented in your presentation, but it's good to repeat.
I will be happy to do this. Yeah. Firstly, when we are talking about a naive person and we are presenting with advanced disease and we are suspecting to have tuberculosis, or we have some of the confirmatory tests confirming that there is tuberculosis, so we need to start the anti-TB medications firstly. It should be for 2 weeks. Then we can start the antiretroviral therapy for this person. There is conflicting data about adding steroids at this point to prevent the paradoxical iris. Also, I think it should be personalized according to the clinical situation. And usually people go for starting steroids for the diagnosis of TB meningitis. For TB meningitis, the time of starting treatment should be a little bit delayed. Usually, we delay the start to 4 to 6 weeks. And if we have cryptococcal meningitis, it is a little more delayed. It can extend to 6 to 8 weeks. For selection of the anti-TB medications, we usually start the conventional therapy by the quadruple therapy available in most of the countries. For the anti-HIV or the antiretroviral therapy, usually now most of the countries are having the TLD or DTG-based therapy. We here should, in the presence of rifampicin, to be using the dolutegravir at the dose of 50 milligrams twice per day. Also, there is a lot of evolving evidence that using rifampicin with dolutegravir 50 milligrams once daily, it does not affect its ability to maintain the viral load suppression, and it's not associated with biological failure or resistance. But this is not the guidelines for the moment. At the moment, the guidelines supporting to be using the DTG double dose. Maybe if we have the situation of unmasking iris, there is a person who has already started the treatment and we found him experiencing some complications. When we tested him, we found that he has the TB coming on the surface. At this point, I do not recommend to stop the antiretroviral therapy because I have been mentioning that usually people are losing their lives due to the HIV and advanced disease. So don't rush to stop or to delay the antiretroviral therapy under any circumstances. But at this point, you can be able to start the anti-TB medications and do close follow-up to such persons. Treating the iris, for sure, we can add some of the anti-inflammatory medications. For sure, we have data about using steroids. There is also some evolving data about other non-inflammatory medications like colchicine, for example. So this can be also helpful that the person can move through this issue. I think it take maybe 2 weeks to get the very high burden of the TB bacilli getting down. Then the person will come back to good health and continue his medications.
Oh, very clear summary. Thank you very much. I will do a follow-up question on that because it's another question about, I mean, you have the advanced HIV disease patient, you screen the patient, and then the patient is not symptomatic enough, all the tests are negative, the X-ray is negative, so you don't have much suspicion about TB or East or crypto, should you start prophylaxis? Which prophylaxis for tuberculosis is the best that you prefer or is recommended for advanced disease patients?
Yes, this is also a very good question. And in this context, I think we have some evidence from a very interesting data about it was called the reality study. I think it was in 2018. It was published in the New England Journal of Medicine, and it was talking about the enhanced prophylaxis package. After that, it was adopted by some of the guidelines, including the European AIDS Clinical Society guidelines and some national guidelines like what we have in Egypt. So this person can start enhanced prophylaxis package like receiving the INH 300 milligrams for the tuberculosis, receiving 100 milligram fluconazole for 12 weeks for the cryptococcal meningitis, and 5 days of azithromycin, 500 milligrams for the non-tuberculous mycobacteria, and single dose of albendazole 400 milligrams. This prophylaxis package can be provided for such a person. And we need also to keep an eye on the liver enzymes and the liver health, because, combining the anti-TB medications with the fluconazole, sometimes the person can experience some elevation in the liver enzymes, especially if he has co-infection with viral hepatitis. So we need to be a little bit cautious while you are dealing with the persons with co-infection, especially if they have evidence of any advanced or significant hepatic fibrosis.
Okay, thank you, Ahmed. Probably, yeah. But is rifampicin available in Egypt?
No, rifampicin is not available in Egypt. We have also only INH and rifampicin. Yeah.
Yeah, okay, yeah, okay, thank you. It's in other countries, it's facilitating the use of prophylaxis for tuberculosis, the rifampicin, one plus isoniazid once a week, 3 months is more sure than the 6 months of isoniazid.
Yes, sure.
Um, one question. Thank you, Ahmed. A question for Lottie, because the reality trial is yeah, proposing fluconazole. But if you have a negative test for crypto and histo and talaromycosis, there is any value in adding this prophylaxis, so you can be sure that they will not be. I mean, there is a need of a trial on this, or?
So there's not been any studies done on preemptive treatment with fluconazole in TM, but we know from MIC data that actually fluconazole is not very effective against talaromycosis. So I think probably not going to be a trial in that based on the MIC data. But what we would really like to do is look at preemptive screening. We're trying to really kind of drill down on the natural history of TM and understand when people first become antigen positive, whether treating them at that point in time before the onset of clinical symptoms improves their outcomes. And I think that will hopefully be the next piece of work that's done in our group.
Yeah, but this data for crypto is available. I mean, the quickest you start treatment is the best for the patient. Maybe there is not for histo and for talaromycosis, but the common sense make that it's positive, the antigen, and probably is worth it to treat. But the question was, the patient is negative for antigens. There is any role of the prophylaxis, or is a risk of increased resistance and cost only? Because before the antigen, this recommendation and this trial mentioned has met the reality. They didn't have access to crack or to other antigen tests for fungal diseases. So should we change this idea to use fluconazole in very advanced patients without any documentation of any fungal diseases? Maybe not. Or what do you think?
It's an interesting question. I think that the role of fluconazole in TM would be limited, but obviously the data and the evidence is there for starting it to prevent CM. So yeah, interesting question, but I think probably not.
Well, we need some.
TM,
yeah. Thank you. Go ahead, Mehdi. I don't know if you have more questions.
Merci Omar. Peut-être une autre question pour
Maybe another question,
Oumou.
for Oumou.
En partant de votre expérience en tant
With
que patiente qui
your
a été
experience as
diagnostiquée
a
portant la
patient who
tuberculose,
received
mais
a
aussi en partant
diagnostic
de
of
votre
tuberculosis, but
expérience
also
de
taking advantage of your
prestataire
experience
de la communauté,
as a
est-ce
facilitator
que
for the
vous
community.
pensez
What do you think?
comment se fait la communication
How
entre le
is
médecin
communication
et le
between the
patient sur la
doctor and the
tuberculose et
patient
quel
when
est
it
le
comes to
rôle
tuberculosis?
par exemple,
And
de
what is
père
the role
éducateur
of the
sur ce sujet, sur le
educator
sujet de communiquer le diagnostic et
when it
donner
comes
les
to
informations sur la
communicate
maladie?
the diagnosis and share
Parce
information
que
about the
par rapport à
disease?
cette question, je pense qu'entre médecin et patient,
Between the
vous savez,
patient and
maintenant,
the
avec
doctor, you know now,
l'avancée significative vraiment de
with
ces différents
the
traitements,
advancement
le
that we
patient,
have
le médecin
seen,
demande
the
d'abord
rhythm
de
is
faire une
different.
évaluation, même aussi nous, en
The
tant que pairs,
patient
nous
and the
aussi, on fait cette
doctor, the patient, the
évaluation de
doctor
la
have an
tuberculose
assessment.
si
We
il y a des
also, we, the
suspicions.
peers,
Quand on a un patient
have
devant
our
nous,
system of,
soit que ce soit un médecin, que ce
assessment
soit
if we
un
have
père
doubts.
éducateur, on doit lui poser des
We
questions,
look for
notamment,
key
permettez de mon
points. We
témoignage,
ask questions. Like
toutes
I
les
said in
questions par
my
rapport à la situation.
testimony,
S'il tousse il y
we
a plus de
ask
deux
a certain
semaines,
certain
est-ce qu'il fait
question.
vraiment
Has he been
nature?
coughing for more
Est-ce qu'il
than
a
two
perdu
weeks?
assez de
Has he
poids
sleeping?
dans les
Has he
deux
been
semaines?
sleeping well?
Donc,
Has
c'est
he
des
been losing
questions,
weight?
des évaluations avec ce qu'on appelle la
So
tenue verbale
we have
qui permet
questions. We
vraiment
can make an assessment,
au
and we
médecin
can
ou au père éducateur vraiment de
give
guider
the
de façon avec
information
le
to
diagnostic
the
de la
doctor or
tuberculose pour
to the
savoir si le
educator, the
test est
person who's
positif
there
ou
to
c'est
help
négatif. Mais
with
aussi, au cas
information.
où le
And
résultat est positif, c'est vraiment
if
une
we
antenne
have
d'encourage qui est là,
positive
dont on fait
results,
pour
we
pouvoir
have a good
préserver
support
vraiment son
system,
entourage. Est-ce
and we
que
can
ouvrir la fenêtre
absolutely
afin qu'il y ait
preserve
une
the
aération au
ecosystem,
moment où la personne est
the
dans la chambre pour essayer
environment
vraiment de
of the
sécuriser
patient.
la
We
santé
can
de son entourage.
isolate this
Voilà
person,
quelques
and we can
questions.
make
Même au
sure that he's
démarrage du traitement,
safe.
on informe
We
aussi que
have, at the beginning of
une semaine,
treatment, we also
deux
have
semaines, il peut vraiment
support
éviter
for
de
2
prendre le
weeks.
même bol parce que chez nous, ici en Afrique, on boit
Here
dans
in
le même
Africa,
verre, que le même bol que tous les membres de la famille. Mais pour
uh,
le démarrage de
we
son
all
traitement,
sleep.
c'est
For
qu'on fait
example,
aussi
we
les
can
15 mètres
isolate them
dans
for
son
2 weeks
assiette,
because, you
les
know, us
entourages
in
et
Africa,
vraiment tous
we live in
ensemble,
one home
vraiment pour qu'ils
and
puissent revenir
everybody sleeps
sans
in the
aucun
same room.
infecter
So we
les
do
autres membres de la famille
everything that
en
we
les
can to
sensibilisant
avoid
pour lui dire que
infection
ce
to
n'est
the
pas
rest
une
of the family.
stigmatisation, mais une
We
discrimination.
want to avoid
Tout n'est pas vexation, suivi pendant le
stigmatization and
traitement. C'est juste
discrimination.
qu'il vraiment prenne les dispositions pour
And
éviter que les autres
we
membres de la
have to
famille
make in
soient
place
aussi
a
infectés.
system
Même ses
so
enfants
the other
sont
members of the
aussi
family
à risque si
uh,
suffisant qu'il y a des infections. Voilà
can
quelques
avoid being
questions,
affected as
des
much as
échanges
the
pour
children
rassurer
also cannot
les
be
patients
infected.
avec
So
nous.
this is how we take
Merci.
care of our patients.
Merci beaucoup. Je pense qu'on
Thank
arrive
you. Thank you very
à la fin. On a
much.
pris beaucoup
We
de
are
temps.
arriving at the end of
Nous
our
sommes
webinar.
désolés
We
de ne
do
pas
not have
pouvoir
enough time.
répondre
We
à
are very sorry
toutes
that we
les
cannot
questions.
answer
Peut-être pour les
all the
trois
questions
orateurs,
you
un
have
dernier
asked.
mot, un message
Maybe
clé
the
avant
last
de conclure.
words could be given by the speakers. Maybe a few words from each of you.
Docteur Cordie.
Dr. Cordie, would you like to go first?
Yes, thank you, Mehdi, Omar, for running this very interesting webinar, and thank you for the IAS team for all the support they provided to us. I think just it is like an beginning for more and more discussions between all the practitioners who are interested in the supporting the people with advanced disease all over the globe to be exchanging the experience and thinking with each other. I think it was very interesting and informative for me, and I knew some new data that I have never been exposed to. So thank you for allowing me this very eye-opening experience, and would be happy to be engaged in future discussions and presentation. Thank you.
Merci. Lottie.
Yeah, thank you
Lottie,
so
would you
much
like to take the
for
floor?
invitation to be part of this fantastic session today, and great discussion afterwards. And please, if you have any further questions, you can contact me by email. I'll leave it in the chat. But yeah, huge thank you to the IAS organisers. Really well-run session and lots of interesting discussion. So I'm really grateful for that.
Merci. Oumou.
Moi, pareil aussi, ça a été un réel plaisir pour moi, Mehdi, vraiment. Merci beaucoup, Monsieur le
Thank
Président.
you so much. It was a pleasure for me. Thank you, Mr. President. And I want to thank all the organizers. It was really a pleasure for me to share my experience, to share what I have gone through. We had a question about stigmatization and discriminations. By the way, these are really problems, but we have to work on the patient. That patient has to have a better self-esteem. And the patient must think that life is beautiful, life continues. There are other diseases, but and everybody must be
Merci
happy. In the
beaucoup.
meantime, this
Merci
was a
encore une
pleasure
fois à nos
to
orateurs,
be
à
with
nos
you.
interprètes également et à tous les
Thank you very
participants.
much to
Et
everybody, the
aussi
speakers,
merci à toute
participants,
l'équipe de
interpreters, and
l'Educational
thank
Fund
you,
de la
of
Société
course,
internationale du
to the
sida.
team
Omar?
that work on this project, the team from IS.
Thank you
Omar, would you
very
like to
much,
say a few words?
Mehdi, for giving also the opportunity to be here with you. It was an incredible, informative webinar. Thank you all the people from the IIS for the organization, also and the participants for continue advocating for caring patients in those tough times. I hope that the high-income country will continue supporting the elimination of HIV and the tuberculosis and also the fungal infection in spite of these recent changes in the financing. And also, I hope this introduction of this new test, lateral flow assay, will continue saving more life. Thank you very much for this. Please take note that to all the participants that one evaluation survey will be launched when you leave this webinar. So please fill this survey for us. Your feedback is very important. So the IIS Educational Fund can continue improving the webinars in the future. The links of the survey is also being shared in the chat box. So please fill the survey, put all the comments that you might have, put there also potential topic that you want to hear in the future. Thank you very much to the audience for participating in this webinar, which has now come to the end. Let participants know that the recording will be available IIS soon. Thank you. Bye bye.